Well, good evening to everybody. Dear colleagues, welcome to today's webinar on the diagnosis and management of hypertensive emergencies. My name is Paolo Verdecchia from Cardiology in Perugia, Italy, and I am pleased to be joined by two experts in this area, Dr. Jana Brgulian from the University Medical Center in Ljubljana, Slovenia,
Hello.
and by Dr. Antoine Kremer from the University Hospital in Bordeaux, France.
Good evening.
The aim of this webinar is to give you a better understanding on the diagnosis and management of patients with hypertensive emergency. It's an important clinical area in which doctors are called to immediate and vital clinical decisions. So it's very important to know what should be done, what should not be done, and what must not be done. And this session is fully interactive, so please send us at any time during the webinar, send us your questions, your comments, and I also invite you to participate in the online session with using the multiple choice question, MCQs, that will be submitted during the case presentations. This program is supported by an educational grant from Servier, and I think I start the ball rolling by introduce Dr. Jana Brgulian, and please, Jana, to hold your presentation. Thank you.
Thank you very much, Paolo. So, dear ladies and gentlemen, it's my great pleasure to be here today and discuss with you these hypertension emergency situations, which are very difficult to handle in our daily practice. We know when we work at emergency that these are really difficult situations, and we sometimes really need to act in a minute. So it's very good that we know exactly how to act. And I hope today you will get some replies to your doubts about handling these emergency situations. And I'm happy to be here with you on behalf of Council on Hypertension, and most of our presentations will be based on the Council of Hypertension position document on the management on hypertensive emergencies. So first I will try to present you a case, and then on the end I will give you some theoretical background. In between, we're going to put you some questions, and I hope you will help us with your replies. So this was the lady, 59 years old. She was admitted to the emergency department due to the shortness of breath, which started in the late afternoon and escalated to the late evening, so relatives were very worried and called an ambulance. When the rescue team arrived, they measured blood pressure very high, as you can see, 240/100. Oxygen saturation was 70%, and put her on a hair mask. And in this matter, the saturation oxygen elevated to 90%. They also, of course, administered some drugs like furosemide, morphine, and also gave her some inhalation. After all this treatment, they transferred her to the emergency department of our university hospital. There we found out in her family history that her father had cerebrovascular insult, mother was operated on heart, but she didn't know exactly why, she didn't know any details. She was having hypothyroidism, and she was on therapy from 2001. And as you can see from all these 3 points, she had atherosclerosis, which was really expressed all over the body. That's why she had PTA on the legs. She also had 3-vessel coronary disease, so her CABG was done in February 2018, and she also had aorta bifemoral bypass and TA in May 2018. For the present history, we found out that she was treated for hypertension for 15 years, and 2 days before the admission, she had breathing problems, which worsened due to the night of the admission. She was taking this medication, so you can see bisoprolol, aspirin, fixed-dose combination of perindopril, indapamide, and amlodipine, and she was on rosuvastatin, 40 milligrams, so quite high dose, levothyroxine, and the most important is that that she was still smoking. She used to smoke for 30 years for 15 cigarettes per day, and she was still now smoking for about 6 cigarettes per day, which is still a lot for her, but she was not convinced to stop. So on admission, her oxygen saturation on her mask still was 94%. Her blood pressure, as you can see, was high, 233/125, and also her heart rate were high. So there was somewhat elevated jugular venous pressure, and above her lungs you can hear diffuse inspiratory crackles and expiratory wheezing, and on the heart there was a rhythmic action with the frequency 130 per minute. No special murmurs were heard, no abnormalities in abdomen, and moderate peripheral edema. So we had high blood pressure and lungs which were affected. And then these are the laboratory results which we've got at the beginning of her treatment. As you can see, these bold numbers, these are numbers which are above the normal level. And you can see that there were white blood counts which are above normal level, so 20. And then hemoglobin was normal, creatinine was higher, so her glomerular filtration rate was diminished, calcium, natrium were normal, LDH was somewhat higher, CRP was raised a lot, you can see 117, and raised a little bit of troponin, and quite a lot was anti-proBNP. As you can see, the number was high. So here comes the first question for you, and we ask you for some collaboration. So I ask you, would you ask for more laboratory tests, or you would be satisfied with I have offered you before? So your first reply would be, yes, I would like to know platelet count and glucose level. Your second reply would be, yes, I would like to know quantitative urinalysis. And the third reply, no, it's enough for starting treatment. And the fourth, we need 1 and 2. So it means that you would like to have platelets and glucose and quantitative urinalysis beside what I have offered you before. So I'll be happy if you give us some reply. I think you have about 30 seconds to reply. And I'm really very much interested, what are you going to decide? Is it enough to start with what we have, or we need more, like platelets, glucose level, urinalysis, both, or just one? So, Paolo, did we get some results?
About 1 of 2, about 48% vote number 4. That means we need both 1 and 2, while only 11% voted 1, only 11% think that I would like to know platelet count and glucose level. Only 8% said, yes, I would like to know urinalysis. And 34% thinks that, no, it's enough for starting treatment. Okay. So 1 of 3 thinks that it's enough. What do you comment?
So I think the correct answer would be number 4. So I would like to have also platelets, glucose level for sure, but maybe for urinalysis, really for start, it's really not so important to have it, especially in my case. But anyway, if I would have it, I would be happy to do it. So I would suggest also to do a wider urinary analysis and also laboratory test, including platelets and glucose level, because it's important to start the treatment.
Okay.
So if we proceed with the case, you can see that this is her chest X-ray. This was done in the lying position, and this is her ECG. So really, the heart rate is high, but nothing so special is seen in this ECG. And then we go to the treatment. So, of course, we proceeded with the oxygen mask. Then we proceeded with nitroglycerin infusion, with nitroglycerin sublingual, and received furosemide, more morphine, this is morphine, and also our infectologist decided to give us a suggestion for 2 antibiotics which should be administered. So this was our treatment. So after a while, her blood pressure dropped to 140, 50 over 82. Heart rate also dropped a little bit, and she was feeling better. So she was admitted to our department, and during hospitalization, we noticed that there was a murmur in the abdomen and transitional decline in renal function. Her systolic blood pressure was 100 to 110. So we decided for abdomen ultrasound and renal Doppler, which was performed. And as you can see, the size of the right kidney was lower than to the left one. And the resistance index was lower on the left side. And Doppler also showed stenosis of left renal artery. So with echo, we showed normal ejection fraction, some contractility abnormalities, and elevated left ventricular mass index. So based on all these investigations and what we've seen and her response to the treatment, we could really conclude that she had pulmonary edema, acute respiratory infection, and based on the Doppler and these kidney sizes and everything, we could conclude that she is having craniovascular hypertension. She had CABG in 2018, and she has peripheral artery disease, and she also had hypothyrosis on treatment. So after she was dismissed from the hospital, we put her on specific therapy, and her blood pressure was in the range for 24 hours. So systolic, diastolic blood pressure. She didn't have any night drop blood pressure, but we are also not so sure if she was really sleeping so good. And as you can see, she didn't have any ACE inhibitors for the start, but we decided to start very small doses and then proceed with the higher doses to see the compliance and also to see what the blood pressure will be and how she will respond with her kidney function. So then I come to my next question. So what is the definition of hypertension emergencies, and is it important to differentiate them from the urgencies? So your first reply would be, these are situations where very high blood pressure values are measured at clinical examination and there is no difference in lowering blood pressure. Your second reply would be, these are situations where very high blood pressure values are associated with acute hypertension-mediated organ damage, and in urgencies, blood pressure lowering should be immediate. And the third reply would be, these are situations where very high blood pressure values are associated with acute hypertension-mediated organ damage, and clinical approach is different from the urgencies. So here we would like to see if there are any differences from emergencies and urgencies, and is it really important to differentiate between these two stages, or this is just high blood pressure which we have to lower anyway, and it really doesn't matter in which way. So that's why I'm asking you, what is the correct definition of emergency, and if we can have a differentiation from the urgencies. And these are your replies, which we are asking you to give it to us.
Well, it's interesting because about 72% of attendees believes in point 3. That means their emergencies are situations different from urgencies. I think that's correct. Answer, correct. But still, 30% of attendees still believe either that response 1 is correct, 5%, or 26 believes that response 2 is correct. 26% believes that in hypertensive urgencies, blood pressure lowering should be immediate. I think this concept should be removed.
Yes,
Don't you think so?
Then we still have to proceed with our presentation, I guess. So.
Okay.
So that's why I'm giving you the definition of hypertension emergencies. So these are very high blood pressure values, but they are associated with the acute hypertension-mediated organ damage. Our key target organs are usually heart, retina, brain, kidneys, and also large arteries. So immediate blood pressure reduction is required to limit extension or promote regression of target organ damage. And the type of target organ damage is the principal determinant of the choice of the treatment, target blood pressure, and also time frame by which blood pressure should be lowered. So if we again look for the stratification between the emergencies and urgencies, we can see that we always start with symptomatic blood pressure elevation. But here comes the important point. So acute hypertension-mediated organ damage is the reason why we differentiate between these two stages. So on one hand, we have emergency, like in this case, and on the other hand, we have urgency. And if we have emergency, then we have different stages, as you can see here. It depends on the organ which is involved. And it's also important that patient with hypertension emergency should be admitted for the close monitoring and in most cases treated with intravenous blood pressure lowering agents to reach the blood pressure, the target blood pressure, whereas in the urgency cases, usually we can go for the oral drugs. And we can, most of the cases, also discharge them after a brief period of observation. So when we try to reply the question about epidemiology, it's not so easy. Probably one of the reasons is that coding difference among the institution is really different. And that's why we can really not have the data which we can rely on. But anyway, we can say that 1 in every 200 patients presents at the emergency department with a suspected hypertension emergency. And despite improvement of hypertension in the past decades, the incidence of hypertension emergencies has really not declined. And the most frequent cases are acute pulmonary edema, stroke, then it's followed with myocardial infarction, heart failure, acute aortic dissection, acute renal failure, and also hypertensive encephalopathy. So the organs are affected, like it's pointed here, aorta, heart, brain, retina, and kidneys. And these are all the emergency cases which we get, and also the time frame how we should react. And talking about pathophysiology, there are not so many clear things. The most data we can find are for the malignant hypertension, and we can see in most of the cases we can find out that there is renal parenchymal disease or renal artery stenosis, or also unrecognized or uncontrolled essential hypertensions. Whereas in the other stages, pathophysiological mechanisms are usually not so clear, and they are just developing during the emergency situation. And what is the blood pressure when they start? It's not easy to reply because it's differentiated according to the patient by itself. At each stage, we have to start at laboratory analysis, and we have spoken already before what tests we should do, and as listed here, I think these are all the ones which are important to start at the beginning of our handling our patient. And proceeding after laboratory tests also with diagnostic examination, I have to stress that we have to take really detailed history, physical examination, but we have to measure blood pressure on both arms. That's very important. We have to take ECG, and then, of course, on indication, all the tests which are listed here, and it depends on what we are doing with the person, what is happening with him, and which stage of emergency is going on. So if I conclude, and I would like to give you some take-home messages, I would say that hypertension crisis should be differentiated in hypertension emergencies and hypertension urgencies, and it means only depending on the presence or absence of acute end organ dysfunction. So correct diagnosis and appropriate treatment are crucial and critical for diagnosis and treatment, and blood pressure should be reduced within 24 hours or 48 hours in patients with hypertensive urgencies, whereas target values should be obtained over a period of minutes to hours in those with hypertension emergencies. And when we talk about the numbers of epidemiology, we can say that 1 in 200 patients at the emergency department is admitted due to emergency. Diagnostics, we go for laboratory analysis like we discussed in details before. We need ECG, we need chest X-ray, and then of course also all the other tests, but it depends on the patient which came to the emergency department and the organ which is affected, and these are all the tests which we should follow. And I think in the end we should say that we should really go farther on, and we should protect patients to coming to the emergency department and start treating hypertension on time. So when diagnosed above 140/90, start treating with fixed dose combination and try to prevent them to come to our emergency department. So thank you very much for now.
Thank you very much to you. Very, very clear presentation. We are receiving a lot of questions, and I'm trying to select some more appropriate questions. One of the attendees asks whether you considered renal artery dilatation and stenting in this patient.
Well, as you see, this is a very complex lady. So her atherosclerosis is really all around her body. So for the moment, we decided to wait a little bit to stabilize first the kidney function, and then probably we'll proceed first with the measuring of renal function, and then proceed if it will come again to rise of the blood pressure. But if the pressure will be stable, we will just wait for the moment.
Another colleague asks for a precise, as far as possible, definition of malignant hypertension to characterize malignant hypertension and thrombotic microangiopathy. Probably thrombotic microangiopathy can be reserved
we can talk
to
about
Antoine.
that just after my presentation.
After you can move the question to your presentation. Other questions are all of in the therapeutic area, so we can discuss later. I don't think any. No, also are in a therapeutic area. So I think. Why do you have to measure blood pressure in both arms? You have already responded.
Yes.
If you want to.
Yeah, I think it's very important to measure, first of all, to see if, for example, there is also some subclavian stenosis. You can have a lower blood pressure on one side than on the other, so the blood pressure is not in the range as we were expecting. And, for example, as we will see it also in the next case, you will see exact explanation one with, for example, with aneurysm of aorta, you can have a different blood pressure on one side or the other. So it's important to do that.
Is there another last-minute question? Is there any blood pressure level that we must treat as emergency despite no organ damage?
Well,
this is important.
Yes,
it's interesting,
yes.
Provoking.
But it's very difficult because we can't say this is the level of blood pressure when we have to do something really in emergent state. So you have to consider all together. You need to have a whole picture, not just the level of blood pressure, but you have to consider all the tests and everything, all diagnostic procedures which are done at that moment.
So there is no precise blood pressure value, threshold value to define emergency or urgency. What matters is the existence of rapidly evolving organ damage that should be correct in minutes. So it's not a question of blood pressure exactly 200 or 180. No, it's a question of organ damage that characterize the emergency.
Exactly.
in these patients, why don't medicate for the stop smoking? Okay,
this is a very difficult, tough. I mean, they will just use all the medications, but they will not stop smoking in many cases. That's very difficult. But of course, you can't say we are not going to treat you because you didn't or you don't want to stop smoking.
Some people do, but
yeah.
Okay,
you can't.
I think that so we can move to the next presentation. The pleasure to introduce Dr. Antoine Kremer for this presentation.
Thank you. So this is my turn to talk about emergencies and urgencies and make the difference between these two situations, which are quite different actually. So the first case is male patients of 45 years old, dynamic manager, smoking daily cannabis without previous medical history, and who is presenting to the ER for headache and dizziness. His blood pressure is, of course, very high at both arms, 210 millimeters of mercury for the systolic blood pressure. And the rest of the examination and of the first test are quite normal. ECG is normal and lab tests are quite normal. So nothing special instead of high blood pressure and some symptoms which are associated to this with headache and dizziness. So the question is, how do you manage this severe hypertension crisis? Proposal 1, there are no criteria for an emergency, so you can discharge immediately the patient. Proposal 2, because of the very high blood pressure, a continuous perfusion of nifedipine is required. Proposal 4, an oral medication is necessary for a quick blood pressure drop. Example, nifedipine sublingual. And the last proposal, rest and quiet are necessary before discharge with frequent blood pressure measurements and indications about correct blood pressure readings at home and appointment with his GP. So this is 4 proposals for this case. Here we are. So back to the main figure of the consensus, which showed that we have a symptomatic severe blood pressure elevation for sure. And the crossword is here. So do we have or not hypertension-mediated organ damage? Here in this case, we have no evidence for organ damage. So we are probably and certainly in the case of uncontrolled hypertension. So do we have some response to the case?
Yeah, 30%, precisely 31% of attendees believe that in number 4, that rest and quiet are necessary before discharging patients with frequent BP measurement, and so that's correct. But 40% believe that an oral medication is necessary for a quick blood pressure drop. Example, nifedipine sublingual. In 39, just now, 39% of attendees. 23% believe in point 2, and a continuous perfusion of nifedipine is required because of the very high blood pressure. 2% are in favor of point 1. There are no criteria for an emergency discharge immediately. The point is 38 plus 21
so
believe
the majority of the audience is for an intervention, medical intervention.
With a quick drop in BP.
With a quick blood pressure drop. So actually, this is not our position because this is a point here. We do not have any evidence for mediated organ damage, and so we do not have evidence for a benefit of the medications in terms of prognosis of the patients. And more than that, we have some data which show that the blood pressure drop, which is induced by nifedipine, for example, can be critical for the patients with some case report of stroke, for example, or a myocardial infarction induced by this very large blood pressure drop. What you can see here is so reported in a paper from Burton that you have almost more than 100 millimeters of mercury in systolic blood pressure drop induced by a small dose of nifedipine. So, as we said previously, primum non nocere means we do not have evidence for the medications, but we have evidence that these medications can occur a cardiovascular event. So no benefit for these medications. So we have to be very cautious with the oral medications when there is no evidence for organ damage. So this is a take-home message from this case here. So severe hypertension without organ damage gives us time to think. So we do not have to use oral medication too quickly. It could be necessary for sure, but not yet. And so the oral medication for an immediate blood pressure drop is not recommended. But we have to discharge the patients with confident and a home blood pressure form to fill or 24-hour ambulatory blood pressure monitoring to confirm the diagnosis and adapt the medications if necessary. So maybe there are some comments of the audience for that.
I think it's a very important point to remark because of the high prevalence of those who responded, yes, an immediate blood pressure drop is required. There is no evidence, but there is evidence of toxicity of sublingual nifedipine. I remember a letter to The Lancet by Franz Messerli 28 years ago, in 91. He informed us that the FDA rejected sublingual nifedipine for treatment of this
because of the risk of blood pressure.
Because of the risk of organ damage. Many years ago, we had the opportunity to show a TIA for a patient who had been treated in the emergency with sublingual nifedipine for a BP of 180 systolic millimeters of mercury without any organ damage. They given sublingual nifedipine, they send you to the outpatient cardiology clinic, and these patients had a TIA that was treated. And so really, in these cases, sublingual nifedipine has caused a profound drop in blood pressure, which is completely unpredictable, and it's very difficult to reverse. So this should be this concept should be abandoned.
So it's more for reinsurance of the patients and of the physicians that we are using this nifedipine. But of course, as you just said, there's no evidence for the benefit of this medication, and so we have to abandon this strategy. Whatever the value of the blood pressure, which is quite high in these patients, but it's just figures, values, it's nothing else. So no organ damage, no medication. I mean, during the acute phase, of course. We have to confirm if there is a real hypertension or not. So the other case, it's a male patient as well, quite similar to the previous one, but presenting to the ER for an intense chest pain. The blood pressure level is the same level as the previous patients, 210 at the left arm, but there are some asymmetrical blood pressure measurement with the lower blood pressure at the right arm. The rest of the examination is quite normal, but we have some abnormalities in the biology test with an increase of the creatinine, of the troponin, and the BNP. When we perform the ECG, we have evidence for a left ventricular hypertrophy with a high voltage of the QRS and abnormalities of the repolarization in lateral, which are quite specific of real LVH. And then, because of the chest pain, we perform a CT scan, which makes the diagnosis of an acute an aortic dissection, Stanford B, starting from the cross of the aorta. And so this is obviously not the same situation that the previous one. And the question is, how do you monitor the tight blood pressure control in this context of aortic dissection? Proposal 1. A continuous perfusion of antihypertensive drug is mandatory. Proposal 2, pain control by analgesic is the main priority. Proposal 3, an oral medication is sufficient until the surgeon takes the lead. And proposal 4, if the first IV drug is not sufficient, call the surgeon. So here we are back to our figure 1 for the diagnosis. And obviously we got the symptomatic severe blood pressure elevation again. But here we have several evidence for hypertension-mediated organ damage with an acute aortic dissection, but as well as acute renal failure. So we are in the situation of a hypertensive emergency. And the acute aortic disease is obviously a vital emergency. So we have some response, sorry.
75% of attendees vote in favor of point 1. That's continuous perfusion of antihypertensive drug is mandatory, but 75%. 9% thinks that pain control by analgesics is the main priority, and 14% believe that if the first intravenous drug is not enough, we should call the surgeon.
Okay,
of course, we should call the surgeon, but in any case,
Yeah, if necessary. But actually, we have a dissection here, Stanford B, which is a medical management. So until it's really necessary, we do not need the surgeon in this case here. For the pain, of course, it's necessary to control the pain, and it participates to the blood pressure level, but it's not the main mechanism. And we need to drop the blood pressure, to control the blood pressure, to reduce the blood pressure very quickly and more efficient, with a lot of efficient. So analgesic medication is not sufficient to control the blood pressure. So here is a drug choice according to the cause and mechanism of the hypertension emergencies. In the case of the acute aortic disease, we see that the timeline to get this target, which is 120 millimeters of mercury, is immediate. So we have to be very efficient with the drugs. And the other goal is to reduce the heart rate, to reduce the strain and the stretch of the artery. So the main medication which is required are beta blockers to reduce the blood pressure and the heart rate, but most of the time it's not enough alone, so we have to add other drugs and intravenous drugs, in particular nitroprusside or nicardipine, which can be used as well. So beside this particular case, this is a figure which shows the different time frame and blood pressure target according to the different situation and the different emergencies. So as we just see here, the acute aortic disease, the blood pressure target is 120 and should be reached as soon as possible. It's about minutes. We have two other conditions which require an immediate efficacy of the treatment for the blood pressure, which are acute pulmonary edema and acute intracranial hemorrhage. And we have three other conditions which allow us to take some time and even to respect a very high blood pressure. This is particularly true for the ischemic stroke, which allow us to tolerate blood pressure about 200 millimeters of mercury without medical intervention. So it's really different management according the pathology we're talking about. This is another way to show the previous figure, which gives some details about the timeline and the medication you can use. In most cases, labetalol and nicardipine, a calcium blocker, are useful. Sorry about that. But you can see that there are other drugs like alpha blockers with urapidil, for example. It depends on what you have in your department. So another question is there a place for oral medication in the emergencies? Yes, there is a place for the oral medications. It depends of the timeline you have. As we just said, for the aortic dissection, there is no place for that. But in case of an overactivation of the renin-angiotensin system, there is a place for the ACE inhibitors. This is particularly true for the malignant hypertension and thrombotic microangiopathy you just mentioned previously, Paolo, as this is the overactivation of the renin-angiotensin system, which is the cause of the very high blood pressure. So this is with this kind of drugs that you could have some good results in terms of reducing the blood pressure. In terms of management of malignant hypertension, in our unit, we are using titration of ACE inhibitors, in particular the ramipril. We're starting with very low dose of ramipril 1.25 milligrams, and we double the dose every 6 hours under control of the blood pressure, of the kidney function, and of the kaliemia as well. And we have some good results for that and no worries with in terms of safety. And in France, we started a registry with all the center of hypertension in France to try to collect more data about that kind of management. And I hope we will have some answer in few years. So
just to
okay.
We are receiving a lot of questions about the management of hypertensive urgencies after the hospital phase.
Yeah.
When we exclude an emergency, we are the hypertension urgency. What to do? How to adjust the treatment or how to start the treatment if the blood pressure remains not normal during the could we discharge these patients with ADH with a recent
of course
rise in blood pressure? Maybe what to do in this patient? Do you send this patient at home without any treatment, or do you adjust
the idea is first to make the difference between the emergencies and the urgencies. It's very important. And then if there is no emergencies, whatever the way you manage these patients, actually there is no big mistakes. But obviously, if it still have headache, dizziness, and very high blood pressure, we need to do something for sure. So probably calcium blockers are easy to use because they allow us to do some biological test and hormonologic test if it's necessary. And more than that, the idea is to always the same and to confirm the diagnosis of hypertension, because we know that we can have a very high blood pressure just because of the stress to be at the ER or because of the headache or because of anything. But we have to control and to confirm the diagnosis with ABPM or home blood pressure outside the hospital. So my message is reinsurance of the patients. There's no real emergency, so we can take some time, be quiet, and start a drug if necessary. My opinion is maybe to start with calcium blockers, but it can be another one. And then send the patients to his GP or his cardiologist to readapt the treatment if he was under treatment, or to introduce
even because some of these patients could be on treatment before, but probably the treatment was not well taken, was not appropriate. So we must give some advice to the GPs how to improve.
But what is sure is that the ER is not the right place to adapt a treatment for hypertension, which is a chronic condition. So we need to take time for that. And the ER is not the right place to do it.
Okay.
So the take-home message is for the last cases. We have to keep in mind that we do not have a randomized clinical trial for all these emergencies. And so the management of hypertensive emergencies is mainly based on consensus from clinical experience observations and comparisons on intermediate outcomes. And the task force recognizes that evidence-based treatment decisions for hypertensive emergencies can be improved in different areas, including the safety and efficacy of oral medication as compared to intravenous treatment for the treatment of malignant hypertension. And last point, screening and diagnosis of the hypertension emergencies remain so far the main objective to reduce the burden of these multiple phenotypes of hypertension. Thank you.
Well, thank you very much. We are continuing to have a lot of questions. One question referring to the last case of aortic dissection. What happens if a patient, an ambulant patient, goes to the GP with suspect aortic dissection? Do you give oral antihypertensive drugs such as nifedipine or nitroglycerin sublingual while sending him to the hospital immediately? In the meantime, what do you do?
So it's hard to answer to this question, but I don't know if I'm not sure that if I was a GP with suspicious of aortic dissection in my office, first I will be uncomfortable for sure. I will call the ambulance immediately, and I'm not sure that we can improve anything with just sublingual nifedipine. Again, in case of a large drop of blood pressure, and we do not have the diagnosis of the aortic dissection, so I don't know. I will send the patients to the right place, which is not the office of the GP.
Another one is asking whether in aortic dissection, labetalol or urapidil, what you prefer?
So, as I said, for the aortic dissection, there are two goals. The first one is to reduce the blood pressure, and the other one to reduce the heart rate to limit the stress on the wall of the arteries of the aorta. So labetalol is for that purpose more appropriate. But as I told you as well, mainly it's not sufficient to control the blood pressure. So urapidil could be a good alternative, or add on the treatment.
I have also a question to Jana, probably, which is the reason why the frequency of malignant hypertension or hypertensive emergencies did not decline over the past 1 or 2 decades, despite better control of blood pressure with the new antihypertensive drugs, with the combinations and so on? Which is the reason?
Well, probably there are several reasons, and I think one of them is that the incidence of hypertension is really getting higher than it was before. The awareness is still not high enough, so people are still not aware that they need to be treated for hypertension. They feel well, even though the blood pressure is high, and they just say, well, it's okay, I have other problems, and they just really don't mind about that. And on the other hand, I think that adherence to the treatment is still very low. And I think that people are really not aware enough how important it is to treat hypertension. And it's really that we need to come to the level, to the target blood pressure levels. Not just they take, for example, if they have, 3 drugs for the hypertension, they take just 1 drug and they say, oh, it's enough. But it's not enough, because you have to count to the target blood pressure level. And that's why you need to have 3 drugs or more. And that's why I think our new guidelines are also much better from the older ones, because we have a fixed dose combinations, which are now in the first line of the treatment. And I think that's also one of the important things. But of course, people still need to take the medications. So we have to raise the adherence.
There are several questions about the role of oral clonidine. Which is the role of oral clonidine in this setting? When did you consider?
I didn't have any experience with this medication, so I don't really know. But again, I think my opinion is that there are some emergencies which require an immediate action on the blood pressure, which implies intravenous drug. And there are other conditions which are emergencies as well, like malignant hypertension, for example, where we have time and we can discuss about oral medication, intravenous medication, but whatever the drug we used, today we do not have any evidence of the superiority of a strategy against another one. So it's
Another question
Well,
is...
maybe here we can just mention about the use of amlodipine. Amlodipine is a very good but long-acting drug. So at the emergency department, usually we don't use it because it takes too long to work. So probably the other calcium antagonist blockers.
Another question is about furosemide in conditions different from acute pulmonary edema. Do you use furosemide also in other conditions?
So the furosemide is a loop diuretic, which imply an hypovolemia and a risk of dehydration. Sorry. And in case of malignant hypertension, it's not recommended because of the dehydration, which is a part of the mechanism which implies an overactivation of the renin-angiotensin system. The diuretic can worsen the response of the renin-angiotensin system. So it's not the good drug for that purpose. And then loop diuretics are not used for the blood pressure control in chronic conditions. So there is no place for this drug.
Another question is, aren't you a bit afraid of giving ACE inhibitors if you suspect renal artery stenosis, maybe bilateral or so?
So it was a question with the question with the revascularization of the arteries, and we know with the clinical trial that the medical strategy is good as the intervention strategy, and ACE inhibitors are part of the strategy for control the hypertension because, again, the stenosis of the arterial stenosis induce an overactivation of the renin-angiotensin system, and if we do not use ACE inhibitors, we cannot control the blood pressure in this situation. So yes, we have to use this class of medications in this case, but we have to monitor very closely the renal function and the potassium level.
Yeah.
What would be your approach to cocaine-induced hypertensive emergencies, or more than emergencies, to have hypertensive urgencies, probably more frequently?
So it's probably frequent, but we have to go further in this specific cause of hypertension, but this is mainly due to an overactivation of adrenergic system. So probably medication dedicated to this target are efficient, like urapidil and beta blockers. But again, we do not have more evidence than that, just supposition and experience.
Some attendees continue to insist about the management of patients with hypertensive urgencies when blood pressure is still high or even very high after the resolution of the urgency. In this case, they are not confident of sending these patients at home. They would continue to adjust treatment or to take these patients in the hospital for 1 or 2 days or so.
The question is, in 1 or 2 days, if the blood pressure is still high, what are we going to do? Because we all have patients with resistant hypertension and with blood pressure which is very high, and we do not have any solution for them. So we do not have to be afraid by the figures and by the value of the blood pressure. We have to increase the medication progressively and take the time to control the blood pressure, but we cannot do that in just 2 or 3 days. And I'm not sure it's efficient to hospitalize patients several weeks just to control the blood pressure in case of no evidence of target organ damage.
Probably the last question, what about aspirin and the high blood pressure with the urgencies and emergencies? To cancel aspirin, to renounce to aspirin, time to restart? Might be dangerous to give aspirin in these patients for the risk.
I think it's more, I'm not sure we have any evidence of that again, because patients with stroke basically have aspirin, so I'm not sure there are some cautions to take for the aspirin? I don't know if you have an opinion on that.
Well, it depends. If blood pressure is really uncontrolled, so around 200, then really you would wait a little bit with application of aspirin. But if he's already receiving aspirin, then it's a different situation. So I think it depends on the person, and it depends on the individual case, however you decide. But if you are applying aspirin, if you are starting aspirin, then it's better to control first hypertension and then apply aspirin. But if it's already on, then you have to think why is it on, what is better for him.
And this also to patients treated with oral anticoagulants.
Yes.
But the blood pressure, systolic blood pressure should be kept definitely below 180, better than below 160.
Sure. Yeah.
Okay, I think we're now approaching the end of this webinar. And I would like to close the session with some slides. I have some final take-home message to keep. The first on your left in the slide is a definition. This has been repeated several times, but probably it's better to repeat it again. Probably we should abandon the term hypertensive crisis. It's very frequently used because the term crisis may not precisely characterize what is the clinical picture. Probably we should use the two terms. Hypertensive emergencies. Hypertensive emergencies, we are characterized by acute and rapidly progressive and organ dysfunction or damage. This is an important point, acute and rapidly progressing organ damage. This is an hypertensive emergency. Versus the hypertensive urgencies that might coincide with severe uncontrolled hypertension without acute or rapidly evolved organ damage. And the treatment strategies is different because in the emergencies, blood pressure must be lowered within some minutes or hours with a target blood pressure depends on the clinical called the clinical picture, the clinical diagnosis, while in those with hypertension urgencies, the target, we have more time to think, we have more time to adjust the treatment, and so probably we have at least 24 to 48 hours in these patients. Regarding epidemiology, the hypertensive emergencies are not rare because it is estimated that out of 200 patients attending emergency departments, at least 1 over 200 do have a suspect, at least hypertensive emergency. And despite the better control of hypertension due to the better tolerated and effective antihypertensive drugs, there has been no important reduction in the frequency of hypertensive emergencies and malignant hypertension over the past few years. So it's very, very important as first step to make a correct diagnosis and appropriate treatment. And this is probably, in my opinion, one of the most important slides, one of the most pictures that remarks the point that there are emergency and emergency. In some conditions, in acute aortic dissection, the blood pressure target is very low, even below 120 millimeters of mercury, but the target could be a bit higher in other conditions, particularly in ischemic stroke. In ischemic stroke, we should not intervene with drugs up to 220 millimeters of mercury because these patients normally have a spontaneous reduction of blood pressure over 2 or 3 days after ischemic stroke, and a marked reduction in blood pressure during this acute phase could worsen the cerebral ischemic and infarct area. If the patients has to be dilated and must have thrombolysis, we have to lower, in this case, blood pressure below 180 millimeters of mercury. And also in patients with hemorrhagic stroke, we should treat the blood pressure to level below 180 millimeters of mercury. Probably the correct target is lower, is between 130 to 140 millimeters of mercury. So there's a difference. And we have also to remind which are the more appropriate antihypertensive drugs in these patients. Labetalol, it's very frequently used. Nicardipine also. Nicardipine is not available in some countries. For example, in Italy, we don't have intravenous nicardipine for these patients. And there are also, of course, furosemide and nitroglycerin for acute pulmonary edema. And so, probably I think that all what we discussed today has been very clearly shown in the ASH position document on the management of hypertensive emergencies, on the hypertensive urgency. I recommend you to read this very, very clear and important article. So I have to close the session by thanking. Thank you very much, Jana. Thank you very much. Sorry. Yes. Thank you very much, Antoine. And I would like also to thank Servier for sponsoring this program with an unrestricted educational grant. So thank you very much for attending this webinar. Thank you.
Thank you.